So we'll spend the next 50 minutes talking a little bit about altitude. And climbers and high-altitude people like to talk about what goes on up on Everest, which is maybe a bit extreme, but altitude affects all of us that go to even the kinds of altitudes that most of us spend time backpacking and skiing at. So we'll talk a lot about moderate altitudes and that as well. This is the Aachen Kilcha copper mines, and it's probably the highest spot on planet Earth where people live not year-round, but for most of the year. They typically go to the lower altitudes during the winter, but during the summer they live at about 16 and work up to 18.5, 19,000 feet, and that seems to be the limit of terrestrial exposure to extreme altitude. It's amazing that not very long ago, and in fact in the 70s, Everest was finally climbed, as all of you probably know, without oxygen. And in 1978, Peter Hobler and Reinhold Messner were able to make their way to the top. I think it's worth reading this just because it kind of gives you a sense for what it's like up there without oxygen. After every few steps, we huddle over our ice axes, mouths agape, struggling for every breath to keep our muscles going. I have the feeling that I'm about to burst apart. As we get higher, it becomes necessary to lie down to recover our breath. Well, there were a number of altitude physiologists that predicted in the 60s and in the 70s and that humans would never climb Everest without oxygen, that it would simply be physiologically impossible for humans to perform the amount of work necessary at those altitudes to sustain not only metabolism but work effort. And it turned out that they were wrong, and they were wrong for a lot of reasons. Some are poorly understood. Greg Bledsoe asked me to improve the multimedia capabilities of my slides, so this is a slide we made. This is a little poster we had hanging at the high-altitude clinic at Ferice at 14,000 feet near Everest Base Camp. And the important thing here is it's just an altitude pressure graph, and I'll go back to it for a sec. And the important thing to remember is, I guess, a couple things. Number one, if you're looking at what happens to humans at altitude, people wonder sometimes, what is it about altitude? Is it the pressure? What is it? And most scientists feel that we really respond primarily to the partial pressure of inspired oxygen, the PiO2. And the PiO2 is simply the product of the barometric pressure times the FiO2, or the concentration of oxygen. Now, the concentration of oxygen at sea level is about 21%, as I believe everyone knows. What do you think it is at the summit of Everest? Right, it doesn't change. So that remains constant all the way up to the limits of space, the composition of the atmosphere. So what changes then is the barometric pressure. So the PiO2 is really a function of the pressure. And so there are a few altitudes that I think are important to remember. At about 10,000 feet, roughly, it depends on the barometric pressure of the day based on the weather and other factors. But at about 10,000 feet, you've lost about a third of the atmosphere. A good number to remember, if you are into remembering these kinds of things, is that at 18,000 feet, so the typical pass altitude in the Himalayas or the Andes or a very high mountain in the Alaska range, you've lost about 1/2 atmosphere. And if you are crazy enough to go climb Everest without oxygen and you're breathing at the top of Everest, you've lost about 2/3 of the atmosphere, and you're standing there at about 1/3 atmosphere. Now, I show this picture of Telluride, and I show it for a reason. Telluride, where I lived for about 12 years, the lights down at the bottom are the town of Telluride, and the lights up at the top are the small town referred to as Mountain Pillage. And it's up above Telluride, only about 1,500 feet or so higher. And it was interesting that when we take call, essentially all of the high-altitude problems, not all of them, but certainly all of the more severe problems, typically high-altitude pulmonary edema and rarely cerebral edema, occur up at the higher altitude. And that's because, well, A, it's higher, but does that really account for the dramatic increase in frequency of severe mountain sickness? Well, it has to do with the steepness of the oxygen hemoglobin dissociation curve. And it turns out that most of us remain pretty well saturated up to about that altitude. And that's somewhere between, say, 9,000 and 10,000 feet. So, when you see the football player run the touchdown pass and suck oxygen, it always makes me laugh because those football players are essentially 100% saturated at sea level even after running those kinds of wind sprints. But that's not true for 9, 10, 11,000 feet where we do begin to desaturate. And that's why the bigger problems tend to occur just slightly higher than Telluride. So we'll talk just a little bit about oxygen. And I guess the important thing to know, and I think probably more interesting than that graph, is to look at some of the numbers. And we're going to spend most of our time today talking about high-altitude syndromes and what happens to people at extreme and even moderate altitudes. But I think for those of you that do intensive care and for the emergency department people and surgeons and anesthesiologists, these numbers are really remarkable. And it turns out that one of the reasons that these high-altitude physiologists underestimated, or what do they say in oxygen, in Washington, over-underestimate, the reason that these things were underestimated is because the amount that humans are able to breathe to protect the arterial oxygen pressures is just remarkable. For example, if you look at the arterial oxygen pressure on the summit of Everest, and these were first obtained during the 1981 American Medical Research Expedition to Everest, where Chris Pizzo, who's shown in that picture, was able to obtain end-tidal alveolar gas samples. And using something called a Bohr integration, you can extrapolate what the arterial oxygen pressures are based on end alveolar gas samples. And it turned out that his arterial gases were about 28, his PaO2, which is just unbelievable. If you imagine a patient in your intensive care unit or emergency department with a PaO2 of 28, it's hard to imagine. I think of equal interest is that the PaCO2, these people are blowing off their CO2 down to 7.5, and nobody imagined that humans would be able to breathe to that degree. And it's certainly probable that if we couldn't breathe that much, nobody would survive Everest without oxygen. So humans are remarkable animals, and we basically breathe a mile a minute. Now, when I was in medical school, I remember learning a lot about 2,3-DPG. That seemed to be the big thing that we talked about when we talked about altitude. And it turns out that 2,3-DPG actually shifts, if you remember this from medical school, or maybe if you're an anesthesiologist, you remember it even now, that 2,3-DPG shifts the oxygen-hemoglobin dissociation curve slightly to the right. And we were told that that decreases the affinity for oxygen, between oxygen and hemoglobin, and that's a good thing because it's given off more readily to tissues. But I always wondered what happens at the other end. It just never made sense that our professors would just discuss one end of the spectrum. So it turns out that if you look at high-altitude animals, and probably the best model I can think of is the bar-headed goose, just showed a picture of it. These are birds that fly at 20 and 25,000 feet and literally fly over the Himalayas. They're not just living at 25,000 feet, but they're flying at 25,000 feet. So you can imagine they have to be profoundly adapted to high altitude. And if you look at these animals, they are profoundly left-shifted. And left-shifting increases the affinity for oxygen and actually helps to load at the pulmonary capillary level. So that seems to be as important as the ability to give off oxygen to hypoxic tissues. Now, there's all sorts of stuff. If we were at a big meeting talking about altitude right now, there may be a lecture or two on acclimatization. We've got 45 minutes, so I'll just say that lots of stuff happens when we go to altitude, but first and foremost, the main thing that happens when we're exposed to altitude uniformly in everyone, essentially, is a very marked increase in ventilation. Now, it turns out that some people tend to breathe a lot more in response to hypoxia than others, and those folks are said to be brisk responders, or said to have a very brisk hypoxic ventilatory response. whereas those that don't breathe a lot in response to hypoxia are said to have a blunted hypoxic ventilatory response. And for years, a number of people, pulmonologists, including a friend, Brownie Shaney, studied HVR in an attempt to predict which climbers might go high and which climbers might not be able to. So if you were planning your Everest trip, you could simply go to a respiratory lab and look at your HVR. Well, it turns out that it is mildly predictive, and people with blunted HVRs tend to do less well, and people with brisk HVRs tend to do better. But Peter Hobler, one of the two climbers that first climbed Everest without oxygen in 1978, has a blunted hypoxic ventilatory response. Go figure. So ventilation. We all breathe more. We increase our minute ventilation at altitude. This is a photograph I put in for historic purposes. There's a picture of me before I started dyeing my hair gray, and it's a picture inside of the tank or the chamber at the Operation Everest II research protocol in Boston. And we took 8 climbers and put them in a chamber for 6 weeks and slowly sucked the air out of the chamber, looking at changes in just about everything you can imagine over those 6 weeks. And people often asked us, and they continue to ask me, why would we put all this effort into a chamber protocol as opposed to just going up to a big mountain? Well, if you think about big mountains, they have a lot of variables: cold, dehydration, exhaustion, malnutrition, insomnia. It goes on. Where you put people into a chamber in Boston, you can feed them Ben and Jerry's ice cream, as we did. We had actually a grant from Ben and Jerry's and pizzas, and they can just sort of sit around as couch potatoes. And you can try to isolate the pure variable of hypoxia. So anyway, we had these guys in there for 6 weeks. They had all sorts of stuff done, including 3 Swan-Ganz catheterizations, one at sea level in Boston, another at 15,000 feet, and a third time at 25,000 feet, and then we took them up to 29,000 feet on bicycle ergometers to actually measure for the first time hemodynamics on the summit of Everest, or simulated summit of Everest. We don't have time to talk a lot about that, but the heart works pretty well at altitude, surprisingly. That was a slide that shows simply something that no one can see, but it's the so-called Lake Louise consensus on the definition of altitude illness. And distilled out, what the Lake Louise criteria say are this, and it's pretty straightforward. We can cover AMS, or acute mountain sickness, in the next minute or two. And that is that generally people that go to altitude develop a headache, plus one or more of the following symptoms. Typically some GI upset. Often these people are anorexic. Usually people that are eating a big plate full of, pork chops don't have high altitude illness. Some form of malaise. They may have some dizziness or mild lightheadedness, and we'll talk more about severe forms where that all becomes much worse. And typically, patients won't volunteer this, but if you question them, they will uniformly tell you that they have disturbed sleep. And it's very unusual for somebody that's doing badly at altitude to tell you they're sleeping like a baby. And the way the sleep feels is sort of like if you've ever had a febrile night, where you're tossing and turning and you're agitated and you have strange dreams. That's what hypoxemic sleep is. And we'll talk a little bit more about some actual aberrations in respiratory patterns during sleep in a moment. So the differential diagnosis of altitude is huge, but there are a couple things I'd like to talk about. First of all, it's unusual for me to go to a website or to hear a talk, especially given by a lay person on altitude, guides. I do a lot of adventure travel stuff, and the guides will typically say, if you want to prevent altitude illness, drink water. How many people have heard that in here? Okay, so half of you. There's absolutely nothing in the research to suggest that drinking water prevents altitude illness. But you paid a lot of money to come to this course, and you're about to hear my own personal research findings. I'm ready to announce at this course that I believe that drinking a lot of water may prevent dehydration. And what are the symptoms of dehydration? Okay, thirst, maybe, maybe not. Come on. Fatigue, headaches. Okay, so typically anorexia or even nausea, malaise, headache. Does it sound like anything familiar? So oftentimes people at altitude are dehydrated and they drink water and they feel better, and so everyone says water prevents mountain sickness. It probably doesn't, but it does prevent dehydration, which occurs concurrently often at altitude. So if I've got a climber, for example, working at Denali, and a climber comes up to 14,000 feet on their first day and they say, "Hey, doctor, I've got some mountain sickness. Give me some Diamox." I'll say, "Okay, have you been peeing? How much you been drinking?" I'll typically have them drink a few liters of water, go back to their tent, chill out in their shady tent. And if they come back in 2 or 3 hours and their headache's gone and they feel better, that's probably not mountain sickness. It's probably dehydration. And then the other thing that I put in blue there, because this list is too long to complete today, is CO. And it turns out that especially in high-altitude mountaineering and winter mountaineering, that carbon monoxide is probably a bigger player than we realize. And climbers that are cooking in tents and such with gas stoves are oftentimes developing very mild CO poisoning. It's probably not a big deal, but when you're at extreme altitude or even moderate altitude, the two can play together to the point where patients become symptomatic. So, it's a good question at altitude to ask, especially during winter operations, whether people are sucking fumes from their stove. Now, sometimes people complain that talks on altitude really refer a lot to Everest and extreme altitude. But looking at the data just at moderate altitudes, and a guy in Colorado named Ben Honigman, looked at data, and the altitudes he used were simple altitudes at places like Keystone and Breckenridge in the Colorado Rockies. And it turns out that in the western U.S., in Keystone essentially, that the incidence of altitude sickness was between about 20 and 40%. So it's not a small amount of people that go to even backpacking, trekking altitudes and develop mountain sickness. In kids, there's been a lot of controversy. Do kids get more mountain sickness or less? And it turns out after many years that the data shows that it's about the same. In this particular study, about 28% at these moderate sort of ski area altitudes. So what does that mean? It doesn't mean that kids are predisposed, but it means that you can't ignore kids. And if you're working in an emergency clinic where you have patients at altitude and a pediatric population, it's hard for infants and young kids often to really complain in a way that presents in a fashion that would suggest altitude. So when you've got fussy kids with malaise at altitude, always consider altitude illness in your differential. Kids get it too. Now, there are a lot of risk factors, and we could spend a lot of time talking about this as well, but it's funny, I'm going to borrow a line from my mentor, who's Peter Hackett. I've talked already about a bit in my other talks. And somebody often, when he's speaking to large groups, and when I was young and impressionable, people would always ask, "Hey, Dr. Hackett, I'm going to Aconcagua in about 6 weeks, and I'm wondering, what can I do to improve my performance at altitude?" And Peter would always just look out at the person asking the question, and he'd go, "Choose your parents well." And it turns out that the biggest single factor in determining your ability to perform at altitude is simply your genetics. And if you're somebody that has a low hypoxic ventilatory response, and probably a lot of other things that we can talk about or you can ask me about after the talk, it turns out you're not going to do well. And no amount of training is going to change that. No amount of drinking water, no amount of anything other than acclimatization at altitude. So if you want to get ready for a high altitude trip, train at high altitude, period. This idea that as you get older, we all sort of fear getting older. But here's some good news. As you get older, your ability to withstand high altitude exposure improves. So most of us actually perform better at altitude as we get older. That's the good news. Now for the bad news. The bad news has to do with the pathophysiology of why that is. And people these days that are looking at intracranial dynamics in high-altitude patients are realizing that the reason we do better as we get older is because our brains are shrinking. And as our brains shrink, it offers increased compliance. So normally at altitude, we develop hypoxic vasodilation, and our cerebral blood flow increases. But if we have small brains and the intracranial pressures start increasing, it just smushes out a little extra CSF and we're good to go. Whereas when you're younger, that doesn't happen, so you develop high-altitude headaches and such. Sorry about the bad news. Oh, I guess I should mention this. I just put pre-existing illness. Back in the olden days, we always wondered, some people would develop Heip and then they'd come back and essentially climb the same mountain at the same rate, and they wouldn't develop Heip, and it was a bit of an enigma. But it's now known that there are predisposing factors for things like Heip, and the biggest one seems to be a concurrent respiratory illness, typically a viral respiratory, either upper or lower respiratory illness. It seems that there may be increases in certain inflammatory mediators that predispose us to Heip when we climb with these kinds of viral respiratory infections. So it may be the next time you go, you don't have that, and you're less prone to develop permeability issues, etc. So AMS, natural history, is pretty much people get it, and typically if you just hang out at the same altitude, it typically gets better. In some cases, it will progress to worsening mountain sickness that we'll talk about, but it almost uniformly improves if you just hang out at a reasonable altitude and or descend or treat it. So generally, AMS is not a big deal as long as you don't allow it to progress. So treatment options for AMS: descend. You don't have to descend much. I mean, if you look at that, it's unbelievable that you just need to go down 500 to 1,000 meters. So often, 1,500 feet, which when you're on a mountain and you look down 1,500 feet, it doesn't look very far away. But moving that far down the mountain will generally improve things. Just allowing natural acclimatization to occur. A lot of people stage at a given altitude for a day or two and just let their bodies catch up. Acetazolamide, which is Diamox. You can take fairly small amounts, and we'll talk about acetazolamide in a moment, but most doctors that aren't familiar with altitude will prescribe way more than this, but 125 milligrams BID is plenty for prophylaxis. Symptomatic treatment's fine. You can use whatever, ibuprofen for headaches, etc. And we'll talk a little bit about portable hyperbarics and pressure chambers towards the end. So acetazolamide is Diamox. Generally, it started about 12 hours before ascent. Back in the olden days, people used to start this 7 days or 3 days ahead. Just forget that. You just need to start it the night before, and that's plenty. And you just continue it until the person's better. And if they start getting worse, you can start it again. It's not a big deal. I wouldn't keep somebody on it just in case they get worse. I'd tell them, just stop taking it and see how you do. And if they feel great, great. And if they get worse again, put them back on it. We'll talk about sleep-related disorders, but for sleep, people are using very small doses, just a half of a half, which is about 62.5 milligrams, seems to be adequate for preventing things like periodic breathing we'll talk about in a moment. Now, nobody really understands exactly how Diamox works. It certainly has quite a few actions. Obviously, ophthalmologists use it for treating intraocular hypertension, but it does a lot of interesting things, including reducing the flow and formation of CSF. But for altitude, first and foremost, the mechanism that seems to be at play is based on this idea that as we go to altitude, all of us breathe more. When we breathe more, we blow off CO2. And so all of us develop this respiratory alkalosis, typically at altitude. After a few days, 3 to 4 days, the kidneys kick in slowly and start diuresing bicarbonate. This is happening at the kidney level. And but when we take Diamox, it just expedites that natural process, helps us get rid of bicarbonate. it causes a relative metabolic acidemia, and that decreased pH is a stimulus to ventilation. The same way patients with diabetic ketoacidosis breathe more, patients at altitude that are slightly acid will breathe more. In other words, it improves their hypoxic ventilatory response. So a decrease in pH is a good thing at altitude, and if you measure patients on Diamox versus off, the ones on Diamox generally have higher minute ventilation. Additional treatments include oxygen, obviously, and if a person can't take Diamox for whatever reason, you can use steroids, and typically Decadron or dexamethasone is used, and the doses are up on the screen. This is just a recap, 125 milligrams starting the night before and continuing it for a few days and stopping it when the person feels better is fine. Now, I usually have a slide with Diamox side effects, and I don't know why it didn't show up unless I passed it. So let's talk a little bit about the problems with Diamox. Anybody want to offer up any? Okay, so it causes paresthesias. Anybody that's taken Diamox notice, well, especially these industrial doses that some patients come loaded on, they come in and they're going, my fingers are tingling and my lips are tingling and my toes are tingling. Not a big deal, but for climbers it's problematic because you want to be able to feel your fingers and toes. Lower doses seem to reduce the side effect profile, but the efficacy in terms of altitude remains the same on the lower doses. So that's one of the huge benefits of lower doses. So paresthesias, anything else? Yes? See, what's your name? Linda. Linda just mentioned the most important thing that you need to know, and that makes beer taste bad. And it turns out, do you know why that is? And Are you a nephrologist? Did anybody ever understand their nephrology lectures? Anyway, that's exactly right. Normally, you don't taste the CO2 on your tongue. When you're on a carbonic anhydrase inhibitor, you're actually tasting the CO2. Normally, the CO2 on your tongue is immediately hydrated. You don't taste it. So when it hangs around, you taste the bitterness of the CO2. So any carbonated beverage. It's related to sulfa, so there's some suggestion that patients may cross-react if they're sulfa allergic, so usually it's not indicated in patients that are sulfur allergic. And it makes you pee more. It's not a big deal. People usually exaggerate that. Oh, it's a diuretic. It's a mild diuretic. It does make you pee more. Oftentimes you need to get rid of that fluid anyway. You know, I just tell people, just keep drinking water and don't stop drinking and just try to stay hydrated, and it's usually fine. Yes?
What about people who are already on a diuretic, like
The question is, what if you're already on a diuretic? In my clinical experience, it seems that the effects of Diamox are the duration of effect is very short. So for the first 12 hours, 24 hours, the person will be peeing a little bit more, even if they're on a pre-existing diuretic, but then it tails off and they just go back to normal. So I don't adjust their potassium or their Lasix dose or anything when they're on Diamox. Okay. So you can use Decadron, we already said, for prophylaxis, and we'll talk a little bit about ginkgo biloba at the end. It turns out that the results, if you want the bottom line or I start yammering so much I don't get to it, the results have been fairly equivocal, even though there were some very encouraging studies early in the decade. So I'm going to talk about a few things that happen at altitude that aren't necessarily altitude illness. I never know where to put these in the lecture, so here they are. I'll call this section stuff that happens at altitude that isn't necessarily illness. And one of the things is certain people develop peripheral edema. And you don't know this woman, but if you did, you'd know that her face looks puffy. And this is not unusual. It's more common in women than men, and more common in women that are premenstrual than women that aren't, but it can happen in anybody. And basically, people start developing this sort of Michelin tire look. And what does it mean? Well, it means that people are holding on to fluid. What do you do about it? Well, what I do about it is if somebody comes to me and they go, gosh, I feel really puffy, or my hands feel really puffy, and I'll just spend some time looking at them. And that's a time where you can ask them how they're eating, how they're sleeping. You might listen to their lungs, etc. In my experience, people that have peripheral edema, they're holding on to fluid, they have a statistically higher rate of developing mountain sickness. But that's the bad news. But the good news is that a lot of people that develop peripheral edema are fine and go on to summit. So it doesn't mean they have to go down. It doesn't mean they're getting sick. It's just a person that I spend a little bit more time looking at carefully. And then I watch them. And if you want to be nice to them, you tell them to hang out at the same altitude. I don't usually use Lasix at altitude, but if you have some Lasix in your medical kit, these people are usually Lasix virgins. So if you give them a homeopathic dose of Lasix, 10 milligrams or something, they typically just pee like crazy and come back, 4 hours later and they go, "Thank you," and they feel so much better. Are there any homeopathists in here? I have nothing against homeopathy, but at a meeting recently I said, "Homeopathic dose of Lasix," and this homeopathist came up to me and said, "I really don't appreciate you using the term homeopathy." And I just said, "Okay, sorry, I was just joking." So another thing that happens is high-altitude retinopathy. And it's kind of scary if you imagine what the eyes may look like at altitude. In Operation Everest 2, we actually did retinal photographs on all of our subjects. Most of us don't hang out in the high mountains with our ophthalmoscopes. But if you were to, in Operation Everest 2, 100%, all 8 of our subjects above 18,000 feet developed high-altitude retinal hemorrhage. Quick review, that's the optic disc. That's normal. That's where the optic nerve comes into the back of the eye. That's the macula. That's the area of your eye that's responsible for central vision. But all these red blotchy-looking things shouldn't be there. And those are retinal hemorrhages. 100% of patients in our study develop these. It's kind of scary. If you imagine that this is what the back of the eye looks like, you kind of wonder what your brain looks like at high altitude. And there's no question that there are microinfarcts and microhemorrhages occurring in your brain at extreme altitude. And we'll talk a little bit more about that in a minute. What do you do about it? You go down if they're symptomatic, and they're usually not symptomatic unless they're premacular. I had a doctor on Everest a number of years ago who developed a huge one and a big central vision defect. And I thought he was schizophrenic at first because he came into my clinic going like this. "Do you see that?" He was joking, but he had this huge field defect. So I said, "Doug, you've got a huge retinal hemorrhage. You need to go down." But he was a doctor, so what do you think he did? He went up, yep. Everybody coughs. We talked about that in the expedition medicine talk yesterday, but everybody's coughing. So people have very dry, irritated respiratory mucosa, and people are sucking dust and smoke in the tea houses. So, typically these people, you can give them hard candies like we talked about. You can put them over the teapot at night and just put a fleece behind their head and have them suck steam. It can make the soup that you're working on a little manky, but it's great treatment. And you'll see it. And it doesn't necessarily mean the person has Heip. And when we talk about Heip, which we're about to, you'll know that people with Heip cough, but everybody's coughing in the mountains. Now, this is something that was very interesting. This is, Peter Hackett had written an article on transient cortical ischemia, and it seemed like a very esoteric article to me on 7 trekkers that developed transient cortical blindness. And he believes that this is associated with patients that are overbreathing in response to the hypoxemia. So they breathe to the point where they'll actually vasoconstrict the blood supply to the optical cortices, which seem to be very sensitive to hypoxemia, and patients will become transiently blind. So I was working in Fairchain, and this woman came in trekking. She was Japanese, and it was her birthday, and she came in, and she had gone completely blind. And after her exam, which seemed normal, I just put her on oxygen and had her rebreathe into a Ziploc bag, and within about 5 minutes, her vision came back. So she was happy. There's this whole specter of deterioration. That picture on the right is old. It's from, I took of Peter Hobler and the two summiting Sherpas that came down with him off Kanchenjunga. But it's not uncommon for people to really deteriorate at high altitude. And, you know, if you read literature about Everest, you read about the death zone. People talk about Everest, the death zone. What does the death zone mean? Well, there's this altitude above which you no longer acclimatize. You may still be acclimatizing, but the deleterious effects of deterioration start to supersede any benefit of acclimatization. And people start losing weight and just develop polycythemia and lethargy and just look horrible. And I had a friend, Ben Schifrin, in Operation Everest too, again, eating ice cream and pizzas and not working very hard because nobody wanted to exercise above about 20,000 feet. And he lost 40 pounds, 40 pounds in 6 weeks. Gave me some entrepreneurial ideas about high-altitude fat camps, but here's my mentor, Peter Hackett, looking not so great up on Everest a number of years ago. And this is the typical kind of emaciated look people develop at altitude. Well, I promised you that we would talk about sleep. It turns out that people develop periodic breathing. Not everybody, but many. And this is not at all unusual. And you can see on the top right, I hope you can, that people develop this very irregular respiratory pattern. People used to call this chain stoking, but I think it sounded too much like chain smoking, so they changed it to periodic breathing. And you can see that the nocturnal continuous arterial saturation shows an average around 70%, whereas you put somebody on just very low doses of acetazolamide. It's one of the most magical things about acetazolamide, is you put them on these small doses and it knocks out periodic breathing, and the same patient is now breathing normally and with their arterial saturation closer to the high 80s, or mid 80s at least. So if you want to treat sleep at altitude, don't give people benzodiazepines. It won't kill them. You know, there's this notion some have that if you give somebody a Restoril, that they'll wake up dead because they stop breathing at altitude. And that doesn't happen. But somebody that's getting sick at altitude and somebody that's not breathing well, I would always try Diamox before trying any kind of sedative hypnotic, because what you want to do is increase their ventilation, not decrease it. If you're going to use a sleeper for somebody that has insomnia and you think it's not related to the altitude, you know, something that's not going to reduce their ventilation like Ambien is going to be a better choice at altitude. Oh, look, I put in a slide, so Zolpidem. Okay, so now we need to really get down to business here and talk about Heip. And Heip is what kills most people at altitude. It is not very common on the ascent to altitude. People that run up Mount Rainier and then down again, they're going up to 14,000 feet, they typically don't get Heip. It's usually people that are sleeping at high altitude. It can occur even without pre-existing AMS, but usually there's some AMS. It's a patient in Farache with pretty bad Heip. So let's talk quickly about the symptoms. So first of all, people just feel lousy. So doctors are always looking for things like pink frothy sputum or whatever, but patients with Heip, they don't present coming up to you saying, look, I noticed some, slight pink frothy sputum this morning. The way Heip presents on a trek is the person that just doesn't show up at the tent. And it's like, oh, where's Joe? Where's Mary? I don't know. At that point, And you, as the medical officer, would want to go out to the tent, check on this patient, and say, what's going on? Why aren't you eating dinner? And they'd say, I can't stand it anymore, your company. But they might just say, I don't know, I don't know, I'm fine. And at that point, fine means they're not fine, and then you ask them more questions, and you find out that they're developing Heip. So that's how it presents. So decreased performance, they're at the back of the group. Often a dry cough early, progressing to a productive cough, but it's not always that way. They're always tachycardic and always tachypnic. Typically not orthopnic. Their wedge pressures are typically normal, by the way. And often they're developing AMS or even cerebral signs because they're becoming so hypoxemic. So don't just assume it's going to present as either Heip or HACE. It's often both. Mild fevers, and by fever I should have put low-grade fever. these inflammatory mediators that can occur along with Heip can cause very low-grade fevers. So if you've got somebody with a 100-degree temperature, 105, 100.5, 101, it can be related to the Heip. If they're 102, 103, you need to look for another etiology typically. And then lastly, of course, RALs. And if you're a doctor type or a nurse type or a paramedic type, you're going to have a stethoscope, and you can listen for RALs. One little clinical thing I want to add is that don't forget that to listen to the right middle lobe, you often have to listen, to the right anterolateral chest. And so I had this nurse I worked with in the Himalayas that I fooled into thinking I was a really good doctor because I would hear RALs and she wouldn't. And after a month, she said, "You are so good. You pick up all the RALs." And I said, "Well, Joy, it's just because I wasn't showing you one thing. That if you just listen right here, you'll pick them up." And every time I heard them and she didn't, it was because I was listening here and she wasn't. So good idea, even if you get lazy in your practice, listen to the right lateral chest when you're at altitude. There you go. There's the right middle lobe. So a couple pictures. This is a guy with really bad Heip on Kilimanjaro a few years ago. We had to pull off. He told me, he didn't mind me using these pictures, but a really nice gentleman that was on an adventure travel trip and just got really sick on the summit. Typically this patchy alveolar infiltrate characteristic on X-ray. There's a Japanese climber I took care of on Denali with a SAT, which is not very accurate, below about 70, but with a SAT that was uniformly reading about 42 to 45%. So what do we do to treat? Well, there's some new strategies, and I'll go through this quickly. Back in the olden days, we used to sometimes give albuterol, but really, why were we doing that? Well, because albuterol does something for the lungs, and this has something to do with the lungs, so let's give albuterol. But it really didn't make sense in terms of the mechanism, because obviously, why would a bronchodilator help for somebody that has fluid in their alveoli? But it turns out now there have been a number of studies, you can't read this, but a study about 7 or 8 years ago in the New England Journal showing that salmeterol, long-acting beta agonists, would actually prevent high-altitude pulmonary edema. And people started using things like salmeterol or even albuterol. And it turns out that beta-adrenergic agonists upregulate the clearance of alveolar fluid, and in animal models at least, and it seems to work well in patients. So now you use your little MDI for treating Heip, and it's not typically used as primary treatment, but it's often used as an adjunct in treatment for Heip. There's Cerebral. Okay. So, a few years ago, it seems like about at the same time, we started talking about Viagra for mountain sickness, and people laughed, oh, ha, ha. But it turns out that in the last half a decade, these PDE5 inhibitors have become sort of a mainstay in the treatment and in the prophylaxis for Heip. And typically for mountain climbers, nobody knows what the right dose is, but about 50 milligrams for sildenafil, or however you pronounce it, and Cialis, which is tadalafil, which some people prefer, is 10 milligrams by mouth twice daily. And Viagra is 50 milligrams by mouth 3 times daily. But those are just guesstimations because nobody knows what the appropriate doses are. Back in the olden days, we used to use nifedipine for Heip, and nowadays that seems to have been replaced for most by tadalafil and other PDE5 inhibitors. Now, why is this? Why would these drugs make any difference? It turns out that Heip is uniformly associated, invariably, with increases in pulmonary artery pressure. Patients with Heip develop pulmonary artery hypertension. So the treatment is directed at oxygenation and rest and reducing pulmonary artery pressures. And that's why calcium channel blockers work, and that's why these phosphodiesterase 5 inhibitors work. So it turns out this is new stuff, and when I say new, I mean in the last few years, that people are starting to use Decadron now. There have been a number of studies that show that you can prevent Heip with Decadron. Nobody knew that until about 2 or 3 years ago. Turns out that Diamox, even though all of us that work at altitude give Diamox for Heip, there was nothing in the literature that really showed that that Diamox prevented Heip, but it's now based on a number of studies that show that you can prevent Heip in Heip-susceptible patients by giving Diamox, and that salmeterol can actually prevent Heip as well. So there are some new prophylaxis regimens now for people that are Heip susceptible. We also use portable hyperbaric bags. The one in the U.S. was invented by Igor Gamow. It's spelled Gamow. And I have this pet peeve where when I go to work at an altitude station, there's somebody that goes, yes, you can go try the Gamow bags. But it's Igor Gamow, whose dad was George Gamow, who's one of the theoretical physicists that in the 40s came up with the notion of the Big Bang. So his son went on to, I guess, more concrete issues like hyperbaric chambers for altitude. Basically, if we had more time, I could talk a lot about portable hyperbarics, but you basically put the patient in a bag and you pump them up. And you can simulate a descent of about 3,000, 4,000, 5,000 feet, depending on your starting altitude and the pressure of the bag. This is HACE, high-altitude cerebral edema. Important thing to know about that is that these patients uniformly get really stupid. But the mainstay, besides just getting stupider and stupider, is that they develop, and if you remember one thing from this, is that patients with high-altitude cerebral edema will develop progressive neurologic deterioration, but really the diagnosis is based on truncal ataxia. So you get these patients up, and you walk them the way the Highway Patrol or state troopers used to for a drunk test, just looking at their tandem gait. And if they have moderate ataxia at altitude, or worse, they can't walk the line at all and they fall off of it, that is high-altitude cerebral edema until proven otherwise. And those patients have to go down now. And you'll hear in these altitude lectures, this is just a slide that shows a lot of other things that can cause cerebral manifestations or neurologic manifestations at altitude. It's not always cerebral edema. You can watch this in the video after the conference. But I want to mention, maybe more importantly, this is just an MRI image of this T2 signal in the corpus callosum on MRI of high-altitude cerebral edema. But more importantly, that's a brainstem in an autopsy that Hackett did. And you can see all of the hemorrhage that occurs just from the pressure. But the most important thing for this group, I think, is just to remember that I've heard that you can see a patient that develops HACE and 12 hours later they're dead. I've never seen that, but I have seen patients that develop HACE and they look like this, and 12 hours later they look like this. And so you really want to walk a patient out that's still ambulatory. You can give them some ski poles, take their pack, help them down. Once a patient becomes a litter evacuation, it becomes a completely different game. So treatment for HACE is descent. Dexamethasone works wonders. And I promise you, if you're a neurologist and you have questions about sometimes Decadron works, sometimes it doesn't, for HACE, it works. And it doesn't take the place of descent, but if you can't descend, it can temporize patients. If you can descend, it improves the situation during the descent. And if you've got a hyperbaric bag, you can stick them in a hyperbaric bag with Decadron and typically keep them alive and well overnight till you can get them down the next day. That's what they look like. That's the French bag on the right, the Certec bag, the Gamow bag on the left. That's what they look like. You pump them up literally with a rafting pump. They pump up to 2 psi. I know there's some divers in here. 2 psi is nothing, but 2 psi is not bad when you're up on Everest and you can descend a patient 5,000 feet by just increasing the psi to 2. Prevention is basically just going slow, using drugs we already talked about, and trying to not climb higher than 2,000 feet for your sleeping altitude per night once you get above about 10,000 feet. So once you're above 10,000 feet, no more than 2,000 feet a night sleeping altitude. That's sometimes broken on these guided climbs like Kilimanjaro and Aconcagua and Everest, but that's what you need to do if you want to stay happy. I'm not going to talk about ginkgo because I want to get the next speaker up, but I will be here to answer questions during the break. And there's lots more to talk about on altitude. When I'm left to my own devices on these adventure travel trips, people hate me because I'll talk about altitude for 3 days. And it's like, can we talk about something besides altitude? So if you have questions, just hit me up